Welcome to the State of State Policy, Opportunities and Challenges for Hospital at Home. We are very grateful for the generous support of the John A. Hartford Foundation for the users group and all of our activities. Here's where you can find all of our Hospital at Home users group websites, Twitter and X, our technical assistance center. You can watch all of our 25 webinars here on our, if you want to binge watch them like a Netflix series. We are currently accepting submissions for poster abstracts, Program of the Year Award nominations, Clinician of the Year awards, photos and videos. Those are all due July 1st, next Monday. We also have an exciting opportunity for research that we're focusing on caregivers and equity. To get involved, please scan this QR code or contact info@highusersgroup.org. And now I would like to hand off this meeting to our moderator, Lisa Tripp. Take it away, Lisa.
Oh, thanks so much, Gabby. Appreciate it. Very happy to be with you all today. And since we got a little bit of a late start, we will kind of move quickly through the introductions. But I'm Lisa Tripp. I'm a partner with Tripp Hollander Advisors. I have a long history with Hospital at Home in the U.S., which means it started in 2020, so for about 4 years. And I co-led the team along with Doug Clark that wrote and implemented the CMS Acute Hospital Care at Home waiver, along, of course, with Danielle Adams and Ashby Wolf and Doug Olson. And Ashby and Danielle still lead that team and have done exemplary work to take us this far with Hospital at Home. So I'm going to toss, we've got a great discussion today, and we're going to save as much time as we can for your questions because I know you have a lot of questions. I'm going to toss to my friend Meredith to give us a little bit of an introduction, Meredith, and how you connect, and then we'll go to Scott and then Kim.
Thank you, Lisa. My name is Meredith Tweedie. I am the Vice President of Government Affairs, Policy, and Regulatory Strategy for Christiana Care. Christiana Care is a nonprofit healthcare system. We span 4 states, have 13,500 employees, and 1,300 hospital beds plus home health. And we recently admitted our 1,000th hospital at home patient, just to give you the very quick highlights. We are in Delaware, Maryland, Pennsylvania, and a little bit of New Jersey, and also very active in the federal policy advocacy space. In the immediate past life, I've been in my role for 7 years. I was chief legal counsel to former Delaware Governor Jack Markell. And before that, I was the head of the civil division for the Delaware Attorney General's office and counsel to the Department of Health and a number of other state government roles. And I will stop there in the interest of time, but looking forward to this. Thank you for having me.
All right, thanks so much, Meredith. Scott, why don't you introduce yourself?
Good morning. My name is Scott Willits. I am a community paramedic by training and background, getting involved with Hospital at Home to help bridge the gap on how to introduce and utilize community paramedics as part of mobile integrated health services within Hospital at Home and other acute care models, advancing the practice to meet where the patient's need is, and working with Hospital at Home to ensure that all of the patient's needs can be met and provided in the home.
That's great. And Scott also holds a number of very important positions. Just tell us a little bit about NAMI-HP, Scott.
So the NAMI-HP is the National Association of MIH Providers. It's the leading association representing MIH services, agencies, and programs across the country, consolidating the conversation and representing a unified voice in policy and regulatory development and industry practices.
That's great. Thank you. And Scott's on the board. And Scott and I work together at Medically Home, where Scott is still at Medically Home. So I want to give a shout out to them as well. Kim, why don't you bring us home with the intros here?
Sure. Thank you. My name is Kim Smoke. I'm the Deputy Secretary for Healthcare Policy and Oversight in the state of Florida with the Agency for Healthcare Administration. I also serve as the state of Florida's State Survey Agency Director. So I oversee all the licensing, regulation, a ton of other stuff in the state of Florida regarding regulatory oversight. And one of the providers that we provide regulatory oversight to is hospitals. And I have been at the State Survey Agency this is my 29th year. So I started as a surveyor, actually surveying our care facilities and moved my way up. And now I'm the division director, and have been acting as a state and in my role as the state survey agency director for many years now here at the Agency for Healthcare Administration.
Thank you so much, Kim. Really appreciate that. And that job is, Florida is so big, it's almost like its own country. So it's a tremendous amount of responsibility to be the state survey agency director. So we really appreciate, Kim, you taking your time out to be with us today. So I'm going to give just a little high level, and then we're going to jump into the questions. And panelists, I'd love to make this as kind of interactive among us as possible, since we can't interact directly with our audience. But so at a very high level, I think the state landscape is remarkably favorable for hospital at home. And so what I mean by that is right now, as we sit here, there's only one state that had previously had operating hospital at home programs that now no longer does until legislation is introduced and passed. That state, of course, is California. But considering the size of our country, the number of states, the fact that there's only one that was a yes and now is a temporary no, I think that's an incredibly encouraging sign. I do think, though, that we should really be very mindful that there's still tons of work to be done. So, for example, most of the states have tied their permission to do hospital at home with it's coextensive with the federal waiver. So that legislation expires at the end of the year. And of course, there is a couple bills moving through Congress right now that would extend it for 5 years. We hope that number stays 5 years. But at the state level, we're going to have either legislation or extensions of previous federal actions, or whatever it is under state law that allows for hospital at home to continue. So if you have a state where it's not yet been extended, you want to make sure that you're talking to your government affairs folks and being active, because we cannot just assume that these state laws will get passed without a lot of effort. I think the secondary piece is also really important, and that's federal regulation. So I'm sorry, not federal regulation, state regulation, of course, federal regulation as well. When states act, they will often start at the legislature, but then the legislature will give the executive branch, in most cases here, it's a Department of Health, an obligation to write rules as it relates to the regulated entity. So when hospital at home is a regulated service, it's a hospital service. And we are expecting, and we know that some states are in the process of doing regulation. So the thing I want to highlight about state regulatory activity is the need to engage with your states so that they have the best understanding about how this program actually works, because it is really easy for very, very well-intended regulators to make rules that they think make a lot of sense, and on their face probably do make a lot of sense. But if you're not familiar with how hospital at home operates, because it's such an unusual departure from the way healthcare is normally provided, you could end up with rules and regs that are just very, very unfortunate and counterproductive, even if it's unintentional. So my ask is that everybody make sure that you are engaged with your regulators, engaged with your members of your legislature, so that the set of rules that we have to operate by are as conducive to safety and health, but also operational success as they possibly can be. So, but the state of the state right now is really good. It's remarkable that there's only one state on the map that's a no. The Medicaid uptake is a different matter. And that's a source of consternation for many of us in this environment. So I think we just have to keep up the work and engage with your Medicaid agency. Explain to them why this is a health equity play, and if you can, get them to come out and ride along with you so that they will understand this program, because this program, for a lot of folks, it creates a bit of a cognitive dissonance. They had the reaction that I had when I first heard it, which was, how in the world can you provide hospital level care at home? I would only go to a hospital if I couldn't be at home. That's a starting point for many people, but people like me and others actually move beyond that starting point when we are educated. So I think let's make sure we engage our Medicaid agencies and engage our regulators, engage with our legislators, and that will give us the best shot of creating the right framework and access for hospital at home. So that's my kind of quick and dirty state of the state. And I'm going to toss now to our first set of questions. And I like the phrasing of question one. So it's first question is, what specific state regulatory issues have you overcome? Talk about some of your successes and some of your not yet successes. So Meredith, let's start with you, and then we'll go to Scott. And then Kim, you can also join in here and give us a sense of some of the issues, although I know it's not very many in Florida that you've had to deal with.
Sure. Thank you, Lisa. So I would characterize the two buckets of challenges that we've encountered on the state regulatory front into general licensing issues and payment parity issues. Everything kind of falls under one or payment issues. Like many things in healthcare, most things fall into one of those two buckets. But on the licensing piece, one, as Lisa very nicely summarized, just making sure people understand the program in the first place, that it is not home health care, it is not any of the other post-acute continuum services. Specific example, there was confusion in Pennsylvania kind of following the expiration of the medical home without walls waiver, and people weren't sure if the kind of regulatory uncertainty or reluctance was kind of conflating the two, or actually specific concerns to hospital at home. And that's since been resolved, but I think a lot of places, including Pennsylvania, were still waiting to see more updates to the regulatory guidance for licensing for hospital care at home. There is also, and this is a unique one, I think, for my organization, because we are headquartered in Wilmington, Delaware. Our flagship hospital is in Newark, Delaware, and you can almost throw a rock to Union Hospital in Cecil County, Maryland. It is, I think, 12 miles. I put it in GPS distance between the two, but you cross a state line and you're within the 30 minutes of driving distance permitted by the current waiver. And so we have a lot of situations where we have, a patient who lives in Maryland and comes to our Delaware hospital, or vice versa. And then, you have the provider side of the issues where you have people that live in one state and work in another. And I think the provider side has gotten easier to navigate with interstate licensure compacts, but where does the patient live and which patients can you serve for us is complicated by the being on 4 state borders issue. The other regulatory challenge, I think, is that, and we encountered this when we approached our Delaware regulatory agency at first, and our paramedic regulators in particular, about what are whatever professionals that come to the house, and I think paramedics in particular, doing, and is it actually paramedic services even when someone comes into your home to set up an Alexa, or do they just need like a home care personnel license? Like, what do they actually need? Because not all of that is healthcare or paramedic services or nurse scope of practice. So in Delaware, we got a temporary waiver for MIH paramedics, kind of like outlining and that took some time in doing. And there is actually, and then we had a task force. As many states, we love task forces. And there is a permanent MIH paramedic scope of practice law that, believe all goes well, it will be signed into law very imminently, which is exciting. And then on the payment issue, I think payment parity and just all of the insurance silos that exist in the current system, states can only extend their regulatory authority to things the state regulates, like their own employees, Medicaid, but their insurance commissioners typically can't enforce extraterritorial enforcement is always a challenge with insurance regulation, ERISA preemption, all the standard payment things, and then just getting your payers to and your Medicaid agency to authorize it in the first place, which requires them understanding that this is offsetting inpatient care costs, not adding costs that need to be in a budget line item, and those kinds of things. And then I won't go down the rabbit hole of pharmacy, but that's another fun licensing payment layer with PBM restrictions that we're kind of navigating through as well.
No, I hear you on that. That's really important. I think calling out the piece, by the way, that a lot of Medicaid folks think just automatically, because most things do add costs, right? When you're adding new healthcare services, you're adding costs. So messaging that the Congressional Budget Office scored the federal bill as budget neutral because it's the same patient, same services, and it's just different site of service, and same payment. So that's a key thing for our folks in Medicaid. If anyone is a state Medicaid agency person here, CMS has said that you don't even need a state plan amendment. You don't even need permission. All you have to do is decide to cover Medicaid hospital at home stays, just like you cover your brick and mortar hospital stays, which is how the Medicare program does it. If you do that, you don't even need to tell CMS. You just need to start paying claims. So thank you for calling that out. And that piece, Meredith, that it's a misconception, I think, that it adds costs. So thank you for that. Scott, give us some of your sort of, wins and not yet wins, but soon to be wins.
I think what Meredith teed it up very well, although probably unintentionally, describing the success that she's had with the waiver and the upcoming language for MIH paramedics, making that permanent. Hospital at home and mobile integrated health and community paramedicine have the synergy of trying to help provide care in the home, where community paramedics started that conversation in the early 2000s. And the conversation has really continued from there, and with the help of hospital at home has given it evidence that paramedics are clinically trained to do these skills. They're just doing them in a different environment. Starting an IV on an emergency patient as part of a 911 call and starting a patient that needs some IV Lasix or an IV antibiotic is no different. The difference comes from who's delegating the order and the environment that the patient is, whether that's an emergency or that's the hospital at home in the acute hospitalization status. Really what the title of this webinar and what Meredith was describing, every state EMS structure is unique, plus the territories. You can't really mimic or duplicate the language from state to state. There are best practices that we can take and we do borrow from, but a lot of the EMS challenges come that we're still roll up on the Department of Transportation or Homeland Security. So having those conversations with those regulators to help them understand why an ambulance driver wants to be a community paramedic to help take care of patients in their home, and they can do it. Now, the paramedics are not trying to replace home health nursing or skilled nursing. They want to supplement the services that they can provide. And the MIH is inclusive of community paramedics and nursing can really help do that. With the ability to carry a medication formulary so they don't need to wait for the pharmacy to dispense meds, to carry point of care diagnostics, the ability to have an advanced equipment formulary so they can truly provide on-demand services as the virtual care team changes that care plan or delegates it to it. From Maryland and Delaware to Oregon and Florida, a lot of states are adopting and recognizing now that community paramedicine needs some structure within MIH to allow this to happen. Allowing them to set up the regulatory bodies, the licensure, the certification, so community paramedics can be recognized and then provide these services in the home because they want to.
Great. That's a great report out, Scott. And just I'm really glad you highlighted the fact that this is not substituting for nursing care. So for the waiver requires we have to have multiple nurse assessments. And in most of the programs that I'm familiar with, it's always a team approach. You've got your in-person, for the programs that utilize a virtual component, which are most of them, there's always, we would say that the registered nurse is the quarterback, and the MIH paramedic or other nurse or other provider in the home is a team that is working together along with the physician. So I think it's a great call out, and appreciate that. Kim, give us Florida. You guys have a great regulatory setup there, but tell us your perspective on wins and not yet wins.
Sure. So definitely our win is it has been easy for us regulatory wise to remove any regulatory barriers. as in 2020, when the program came out and the federal government waived the condition of participation, one condition of participation for hospitals to provide acute care hospital at home, we followed suit. So we have a rule in Florida, so we're able to waive that rule as well, specifically about nurses at bedside, because we know while nurses are definitely available at the hospital at home, they're not really at bedside as in your brick and mortar hospitals. So we were able to very easily do waivers kind of in line with the federal hospital at home. So it's very easy for us to do and break down those barriers to do that. To kind of piggyback on the conversation about community paramedics in 2022, Florida did pass a law to allow for paramedics. So it expanded the scope of practice for our Florida paramedics to provide care to hospital patients being treated in their own home, and also expanded the ability for institutional pharmacies to provide medications to inpatients and outpatients without securing a community pharmacy permit. So again, a couple of regulatory barriers and the community paramedic side, pharmacy side, and then just that general oversight of regulatory of hospital patient care and services being provided that we broke down. Some of I guess that as we were moving forward, the other issue that we're, just now kind of really trying to roll out here in Florida for our 25 hospitals that do have the approved program is the Medicaid piece. And just like many other states, Medicaid systems, just trying to operationalize how that would work. While we know CMS is pay it, reimburse Medicaid as you do bricks and mortar. Most Medicaid agencies in states like ours have to operationalize that, add it to our state plan, provide direction where managed care say, so provide that direction. And we've had a lot of great conversations with Lisa and her team as to how we're going to do that. And we're still having those conversations. And that's the next big step for us in Florida, is to move into the realm of Medicaid covering these services, just as Medicaid covers hospital and brick and mortar.
Appreciate that, Kim. And it was great to have to spend some time with your Medicaid folks last week. And I think that it's just hitting the same theme again. We really have to engage as a community. And speak to people and reach people who are not in this echo chamber that a lot of us live in around hospital at home. So I think Kim makes a good point. These agencies have to make their own decisions, and they got to weigh pros and cons. So it's our job to make sure, hey, let's make sure they have the right information about how this does drive health equity, and how it's a one-for-one payment. At least the Congressional Budget Office has decided it's budget neutral. So appreciate that. So I'm going to direct this next question, and Kim, you kind of teed this up a little bit with one of the statutes you guys passed in terms of scope of practice. Scott, the CMS acute hospital at home waiver and the legislation extending it was the first law in this country to ever expressly allow, from a federal point of view, MIH and community paramedics to be part of inpatient care. So what I would love to hear from you as our resident MIH expert and truly one of the most knowledgeable persons in the country about this issue, has that had any spillover effects at the state level where you've seen action to do like Florida did, expand scope of practice or other things?
It absolutely has. It's required some acknowledgement from the state regulatory offices in whatever structure that state may have, to understand that they can't continue to have a passive position on community paramedicine, that they need to take action and set standards and regulatory requirements for it. Oftentimes, there are a lot of states that don't even set the regulatory requirements for paramedics. Falling under the Department of Transportation, they govern the vehicles and the equipment, not the individuals driving or performing medical acts in the vehicles. So they've had to modify their standards and their strategies on how do they actually oversee that. Now, it has caused some confusion and some complications when the states take the position that their unique regulatory structure is truly unique, and they don't look at how other states are developing their own standards. The term community paramedicine or CP or mobile integrated healthcare or MIH, if you look right now in active regulations and legislation and rules, there are 13 different nomenclatures all playing on those words that really make it difficult when then how do you say an MIH paramedic satisfies a community paramedic job description or regulatory requirement when we have those different nomenclatures. But the acknowledgement with CMS in the waiver has also done a tremendous amount of good. Typically, our reimbursement for EMS and paramedic services are actually when the wheels turn, not when the paramedic is actually doing services. Now, alternative treatment in place and alternative destination, the ET3 models, started to change that, but so has hospital at home, recognizing that the work that the community paramedics are doing as part of MIH or MIH paramedics, that they're doing services in the home, but the patient doesn't need to be transported. So they're starting to revise their payment models, whether it's hospital at home, it's hospice, it's palliative care, any of the acute care models that the community paramedics are acting as that physician delegate in the home, that extension from the command center nurse to be the eyes, the ears, sometimes even the nose for the clinical team in the home, that they need to be paid for their services appropriately so that model can be sustained and then standardized to grow.
Yeah, that's great, Scott. And just to also call out, like in a DRG type of payment or a case rate payment, we're not adding costs for paramedic services. We're just taking that DRG payment and we are paying for all of the services under that. So it's not increasing costs from a payer perspective to have MIH paramedics perform these services. So appreciate that, Scott. So let me go to the next question, and we'll start with you, Kim, because you are our state expert here. What would you say to state? Well, let me back up. I'm going to let everybody else go, then I'll let you go because I don't want to put you on the spot. Meredith, what would you say to state officials who are skeptical or hostile to hospital at home? Like, you've had those conversations. So what's been the magic words that have gotten people over the hump?
Yeah, I mean, it depends, of course, on their specific concerns and, taking the time to understand them. And I think they look different based on, kind of to Scott's point, the jurisdiction of the regulatory body that you are in front of, and just sort of the dynamic in the state. So in Delaware, we experienced initially with the paramedic regulators, who are actually under our Department of Health, but in a structure that took me like a year to understand. But it like under public health and under anyway. In Delaware, it was about the workforce. I think that was the foremost concern, and it was about are we going to be kind of cannibalizing ourselves and taking away active paramedics that we badly need to keep doing what they're doing, and having a conversation about how we have an aging population. We have a lot of folks who can retire, and typically, I mean, in those EMS and type roles, you can retire early, but so like there's a real opportunity for people to come out of retirement and work part-time and maybe to create some new workforce opportunities in a different capacity. But it was really workforce was very top of mind. Of course, there's the quality, safety, cost issues, and that's where, to Lisa's point earlier, inviting them to come and visit, do a ride along, meet with your folks, show them the quality, show them the data. And I think one of the more effective things that we have done in conversations is kind of talk about the system, like the impact of this on the system writ large. So Delaware and Maryland have been cited unfavorably in some of the recent healthcare press as having some of the longest ED wait times in the country. I think they were number 1 and number 2 respectively. And so one of our ED bottlenecks is lack of, inpatient beds. And so if we don't have to admit a patient to a bed or can free up the beds, we reduce the ED bottleneck. And just about everyone has personally or, experienced or had a family member or close friend experience, the ED bottleneck issue. And also just framing it as what would you want for your own family members, just sharing, everyone also has their own set of anecdotal experiences. But, I had a family member who was hospitalized for 9 days one summer because of a need for like IV antibiotics and drains and things because of a pretty bad bout of pneumonia. But I mean, feeling like most of the time, I'm like, if we could just get a nurse to come to the house, this, like, we wouldn't have to sit here all day and be here. And same with, things like heart failure, like blood pressure, like monitoring, calibration, like just those admissions, kind of those examples of like, what would you want for your own family members, can also be really, I think, powerful and helpful in kind of thinking through, depending on the specific issue that they have concern about, of course.
I think that's a great response. And I'm going to toss to Kim and Scott. I'm going to let you kind of end us here now. But Kim, like, what do you say? Did you have to deal with the issue that Meredith talked about in terms of the concern that if we allow paramedics to play this role, that would cannibalize the EMS system? Did that come up in your discussions in Florida?
No, not really. I think early on there were some discussions about workforce, as Meredith mentioned. Those are always at the forefront of everybody's minds, but not so much with the paramedics. I think it was we really, in Florida, really try to think have forward thinking when it comes to healthcare, being innovative, and we felt this was a way to do that. And it's kind of as a not so much why we don't want to do it, but why not do it is, I think, the way that we approached it. And our agency for Healthcare Administration, works closely with our Department of Health, Emergency Services, that oversees the licensure and regulation of the community paramedics and EMS services in general. So we have worked very closely together. So I think that's one thing too, that we both in our individual agencies thought there was, this is a great program for us to be innovative and move forward and, in Florida and break down any regulatory barriers. I will say, as the head regulator in Florida that oversees all the regulations of our healthcare facilities, it's always good for hospital systems, our individual hospitals, as they want to move forward with this program, to have some of those discussions with your regulators, and bring them on board early. And that's one thing that did happen in our state as soon as we kind of found out about the program. And I had some long discussions with Lisa, who was at CMS at the time. And because I was a skeptic myself, but we talked about it. And then, having conversations with the first hospital that did it in Florida, that hospital was very open to sharing. They didn't see it as oh my gosh, I don't want the regulators to know, I don't want to share this with them. Very open to that. And I think that's really has helped us, really breaking down those silos of conversations and I don't want to share this with the regulator because, or us as the regulator saying, well, they can't do this, I'm saying no. It's really breaking those down and understanding this is to better healthcare services for all of us, not just a group of us, but for all of us. And so I think that's been very helpful too. And as Meredith said, welcome the regulators and the lawmakers in to your home essentially and say, hey, come in, let me show you this. And that's what our hospitals have done. I've visited many of our hospitals that have the approved program that have the waiver to come in and see, and this is how we monitor. This is a video of what we do. These are, our data metrics. So it's been very, very positive. And I know there's been bumps along the road, but I think sharing all those, the negatives with the positives, are very helpful for folks to embrace the program. Thanks, Lisa.
No, I really appreciate that, Kim. And there's a question in the chat about which states are thought leaders. Florida is obviously a thought leader in hospital at home innovation. I think so that's one. And I also love the fact that Massachusetts is a thought leader in this. So you can see we have there's not a political divide in terms of the support and willingness to innovate in this country. There are other states that are definitely thought leaders as well, but and they don't break down neatly in any kind of political categorization. So that's really nice that we have that. Scott, I'll let you kind of give us a last word about how you've overcome. I know you've talked to some skeptics along the way. How have you overcome those objections?
Yeah, specifically with the concept of paramedicine coming to the home as part of the care team for acute hospitalization has really been around the workforce and the fear that a paramedic in this role is one less paramedic responding to an emergency. And it really comes down to acknowledging that it's not a healthcare system, it's a healthcare ecosystem. To what Meredith was talking about, that one patient in the home is one bed that's available on the floor. And you can build a hospital at home program. Building a hospital is a heck of a lot harder to do and a lot more investment, a lot more time. But having the acknowledgement that an MIH paramedic can see 4 or 5 patients in a day, that's 4 or 5 patients that are not up on the floor of the hospital, that contributes to the investment that now their 911 counterparts have a greater chance of not holding the wall time for 2, 4, up to 12 hours in some cases.
Scott, can you tell us what wall time means? Because not everybody's familiar with that phrase.
So wall time is the industry frame or nomenclature when a paramedic still has continuity of care for the patient while they're on their stretcher, but have not checked in the patient to the emergency department to transfer care to the facility because there's no bed or nurse or physician staff available.
I'm glad you brought it up. It's a critical problem in a lot of places. If you read anything about the UK, for example, the waiting, basically you've got a line of people waiting to drop off their patients at a hospital. There's no room in the ED. There's no room in the hallway. There's no room in the closet. None of those things. So they're just holding there, which means, of course, they can't be out doing anything in the community. And last thing, Scott, in terms of what's this like for the workforce? Like, what does this add? What is this as a career opportunity add to the EMS, the paramedic workforce?
In talking with regulators, right, everyone wants to see the data around the assumptions or the claims that the workforce is short. And we can feel it when talking to businesses and departments that are trying to hire. But one of the challenges we have is we don't have the data to support the status of the community paramedic or even the paramedic workforce. We're not identified as a profession within the Department of Statistics and Labor. So we don't really have an actual metric on what is the workforce. But when you talk with the people, a lot of people are starting to see that this is a retention effort. These are paramedics that otherwise would have left the field because they were physically, mentally, or socially burned out, and that they wanted an alternative in healthcare. And going back to this founding of how EMS started, from arriving to the patient, transporting them without providing care, then adding stop the bleed and cardiac and now trauma and other care, paramedics want to help. They want to do this. Not every 911 paramedic makes a good community paramedic, but by having the states allow community paramedics to develop and set in those standards allows a new workforce or a new career path where paramedics would have their career end because of a physical injury or burnout on the ambulance and have no choice but to leave the EMS profession.
I appreciate that, Scott. And I think the same is true in the nursing space as well, right? We've heard from many programs. They've been started with nurses who love nursing, don't want to leave nursing, but the physical demands of being on the floor at the bedside in the hospital for 8, 10, 12 plus hours are just more than they can do. So the opportunity to provide nursing care through that virtual forward team approach has really done a lot to keep nurses in the workforce as well. So appreciate that. It's about 1:45, so I'm going to jump over here to the questions in the chat. I can, someone asked when we say, and I apologize for not defining MIH, but it's mobile integrated health care paramedic. So it's basically another phrase for a community paramedic. one who is not operating in an emergency sort of capacity. There was a couple questions one question about nursing unions. The state where we have heard the most from nursing unions has been California. So I do not think that it's necessarily the nursing union question has been a particularly big issue in other states, but certainly in California that is the case. The question here about controlled substances. Meredith or Kim or Scott. So the question basically says, how have other states handled controlled substances administration approval? Were there specific rules or regs from the Board of Pharmacy or Drug and Narcotic Agency? So Scott, do you have specific, and Meredith? Okay. Scott, go ahead, and then Meredith, you follow up.
Yeah, so the requirements and the rules that govern how an ambulance maintains their narcotics also applies to the community paramedics. So they have the ability to carry controlled substances from opioids to Suboxone and even Versed and anti-epileptics. Now they can't dispense the meds, they can't leave the meds available in the home for a future dose, but they, upon delegation from the care team, can be scheduled or they could rapidly deploy to the patient's home to administer those controlled substances as part of the care plan.
Meredith, what did you want to add about this issue with controlled substances?
Yeah, I similar answer to Scott's. When we first approached this in the pandemic, in the immediate, when the waiver was first issued and we were standing up our program and had an MOU with the state paramedic agency, our MOU, I think, if I remember correctly, had an appendix that actually had the entire formulary. And that was a pretty involved discussion of our, pharmacy and hospital at home operations team and the state about what that would look like, which is, a thing I never would have even occurred to me necessarily, being a non-clinical, non-paramedic, non-pharmacist person, but as a layer that took a lot of time and thought. And I will also just note that a couple of the states we're in, we're seeing new state-specific controlled substance like certifications that are needed on top of the DEA certification. And I think that's a response to like the DEA, I'm using the wrong word here, but the DEA's permission to prescribe controlled substances for type of healthcare provider who has that within their scope of practice. And because the interstate medical licensure and nurse licensure and the different compacts are taking hold in states, I think they're wanting to have a tighter a set of control, have some accountability for who is prescribing controlled substances, in their state lines that doesn't have the home state like base license. So that's a new trend that we're just kind of monitoring actively right now.
Yeah, no, appreciate that. There's a similar question about are we seeing in some states that meds must be filled or dispensed via inpatient, and in other they can be filled or dispensed via retail pharmacy. Question is, what determines this? And I think the answer is that's generally going to be an individual state law question. So there's no particular federal component. Scott, did you want to chime in as well on the controlled sub? Well, you did actually. How about the pharmacy pieces in terms of inpatient versus retail? Is that something you've dealt with very much?
Yeah, a lot of the conversation really comes to regulators and even stakeholders of the health system wanting to do a hospital at home. They want to do it just as they would as an inpatient. So they want their inpatient pharmacy to do it. And then they start getting into the workflow development, realizing that they have to dispense 24/7, that someone, a pharmacist or a tech, has to be there to verify the orders. And then they start to realize that it's not a sustainable model for them without increasing their FTE. So a lot of are supplementing their inpatient pharmacy with the outpatient retail pharmacy as an option. And then building in, of course, you dispense meds, a courier has to take the meds from the pharmacy to the patient, or the patient's family can volunteer to pick it up as well. We always have that option. And one of the big benefits of using community paramedics is they have that medication formulary. Typically, it's between 80 and 100 different medications and can be expanded based off of the program's needs, but then they're always available to be administered upon the delegation of that virtual care team.
Yeah, and it's a great point. Like, so this is what part of what makes this model of care so exciting, but also very complex, right? Because if you're in a brick and mortar, then it's pretty clear your meds are going to be coming from the brick and mortar inpatient pharmacy. Trying to make that the exact rule that we should follow when patients are far away from the inpatient pharmacy. And we have in places where we have MIH paramedics, for example, who have a formulary on the truck. There is a safety advantage to having the drugs that are needed closer to the patient, so long as the medical staff of the hospital at home program has thought through all of the different workflows and health and safety issues to make that the right thing to do, and also using retail pharmacies. So this is why this is a very complex area. It's something that varies a lot by state in terms of how flexible they are. And I do want to also call out one thing here, as somebody who is a former regulator myself. There's a lot that's written. You take a law that's written 10, 15, 20, 30, 50 years ago, and it had a very specific idea in mind. And when you try to apply that law now to a paradigm that is entirely different, it asks a lot of our regulators to do that, but we ask them to regularly. So I'm saying that by way of a sort of a push toward the best case scenario regulatorily for hospital at home is to have the right set of rules that are appropriate for the manner in which care is delivered here, not necessarily trying to backfit into a different type of thing, in my personal opinion. So that's something, of course, that we will be working through over the years as this program becomes more and more mature. All right, it looks like it's 11:53. I am, oh, and Meredith, you said MOU, so I'm assuming you meant memorandum of understanding with your pharmacy folks. Is that right?
I did. Sorry, yes.
That's all right, no problem. So we have a question here. Are other programs taking patients covered by an MA plan in an observation status and treating them under a hospital at home model? If so, how did they obtain regulatory approval, since CMS waiver is for inpatient status only, who granted a waiver to the MA plan? That's a complex question, and it is there are different legal entities that could be providing care in a particular circumstance that may not be a hospital per se. So I think that might be the answer to some of that question. Meredith, did you want to jump in with that?
Sure. I mean, we have not solved for the MA plan issue yet. I think having alignment with one of your big MA payer partners, if there's a predominant insurer, or same on the Medicaid side, actually having alignment, getting on the same page with whichever payer has, a large share of the patients that you want to use the program for, is always helpful. But MA has layers that we have not fully solved for. And so the other just related point to that, Lisa, is PBMs to like enter into that formulary and who can do what, just like getting into all the pharmacy, like white bagging and brown bagging and like which medications to which patients. I think, broader than MA, but this is like a broader, PBM issue across the board that also, will be a challenge.
Sure. The pharmacy benefit manager has been something that's really been a hot topic here in DC, I know. And I'll just sort of loop back just to tie this up in terms of hospitals providing observation status at home. There's a bill that Senator Carper and Senator Rubio introduced in the Senate that is asking CMS to do a pilot of that. And so while just speaking for myself, certainly support OBS at home. It does create a bit of complexity if one bill goes down the road of a pilot and the other is an operational waiver that is not a pilot, that it can create some difficulties. But I think the answer to the question has to do sometimes with the legal entity actually providing the care. There was a question here about, do we anticipate a reduced DRG payment for a permanent hospital at home program? I can say certainly everyone is talking about that. It is unclear whether or what that would be. And it's unclear the process by which Congress would go about making that decision and the data that they would use to make that decision. The follow-up question to that is, will it be sustainable with a reduced DRG? I think I think that there's a clear no if the DRG cut is X, and I don't know what X is. There's a clear maybe if it's something less than X. So I think that's a really important question. And Congress asked CMS to evaluate the costs of providing hospital at home as part of its report that's due on September 30th of this year. It's unclear whether or not CMS will be able to do that. And I would add, you do have a few studies that have a very small population that might show, a 30% savings in X, Y, and Z. That is very different than actually standing up a program where you have to have 24/7 services to people who could themselves be as many as 60, 70 miles apart from each other. And so it is, at least until there's a scaling, creating a financially successful program is going to take time until the infrastructure is worked out. And so that's one issue I think that we should message in our advocacy work. So I think that's probably, it's 11:58, and I think we answered almost everything, and appreciate everybody's questions here. I don't think we got everything. The whether or not hospital at home beds count toward licensed beds, or if there's a CON, is a state-by-state issue. But we want to say thank you to Gabby and Patricia and to the users group for creating this forum. I think it's incredibly helpful to have our amazing experts like Kim Smoke, Meredith Tweedie, and Scott Willits, who are all wonderful people and dear friends, come here and talk candidly about some of these very complex issues. So thank you very much to everybody at the users group. And thank you so much, Gabby.
Thank you so much, everyone. Thank you, Lisa, and thanks again to our wonderful panel. Just a few closing notes. We are asking for help to connect with hospital at home caregivers. So you can get in touch by scanning this QR code on this slide or contact info@howusersgroup.org. And then save the date for this year's virtual Hospital at Home Users Group annual meeting scheduled for October 17th. And please submit your poster abstracts, Program of the Year, and Clinician of the Year nominations and photos and videos by July 1st. And visit our website for more details on how to do so. We also encourage everyone to head over to our website and check out our full catalog of webinars. You can also see our Technical Assistance Center and our full policy education as a featured resource page. And finally, we would just like to say thank you to all of our attendees and to our sponsors, the John A. Hartford Foundation and the American Academy of Home Care Medicine. And thank you, everyone. Have a great day.